politically supported CCOs, and I think they do a good job. However, I have a lot of concerns. I've voiced those concerns. I was part of the gang of six that helped put together the legislation, and during the process of that legislation, failed to apparently get my point across that we have a lot of concerns in a very, very complex world of working with CMS, the federal government, on a 1115 waiver. Those are waivers that the state of Oregon receives every 5 years to continue to do our process through the Medicaid system. In 2015, I worked long and hard with the Oregon Health Authority to get dual eligibility veterans and seniors to be able to be included into the CCOs. I'm proud of that work. That was successful under our current 1115 waiver that we received January 12th of this year, extending out another 5 years. That is about the most stability that we can get. Part of that process, Ron Wyden, under a different administration, helped co-write 1332 waiver that says we can do additional things, we can draw down additional funds. The current administration has sent out Tom Price letter, as we refer to it, on a 1332 waiver, giving states 9 bullet points of what they can do to try and achieve that 1332 waiver. In a 7-page letter that we will be able to present to you, DCBS, through their 1332 waiver recommendation committee, reviewed that. And on March 1st, they came out with the findings. I won't bore you with all of what a 1332 waiver is, but DCBS came to the conclusion on page 7 of their determination that the committee recommends that Oregon not pursue a 1332 waiver, given the expected 2-year timeline for securing a 1332 waiver under existing rules, the ambiguity about future changes, limits, and the opportunities into the federal health reform. The feasibility of applying for a waiver should be reevaluated when new federal regulations or guidelines are available. DCBS told our group, do not do this 1332 waiver. Do not hinge your Medicaid system on a 1332 waiver, because of the 11 waivers that were currently applied for going forward that hadn't been approved under prior administration, one waiver, Alaska's waiver to fund their Medicaid system. The only state that does not do a hospital tax assessment, ramp up, whatever you want to call, give some dollars here, we give $4 back. There's one state that doesn't use that system. They are the only state that is moving forward with the 1332 waiver. So when we presented from the House Republican Healthcare Committee an alternative bill, we didn't use a 1332 waiver. We used a system that was about 90% the same as 2391, but something that avoided the pitfalls that DCBS recommended not to use. We used $50 million that was currently in OHA from a prior reinsurance program that was being discontinued just last week. We wanted to take that money and put it directly towards Medicaid so those $50 million could turn around and turn into $200 million, guaranteeing our Medicaid recipients would be able to have a better chance of those funds being solid under our current assessment process, adding that to the tax waiver process where we do the hospital assessment. We wanted to take the $50 million we talked about today that was swept away in the master settlement agreement, the one-time bump. That's $100 million that could be matched up and cover tens of thousands of Oregonians. Those funds are not directly allocated to Medicaid. They, again, partially are put to hinge on a 1332 waiver that our own DCBS has told us is a risky venture. 3 editorial boards across the state reviewed the information that we provided for them, and they agreed that looks like a risky venture. That looks like...
Excuse me, Representative Bentz yields his time.
They said, the Oregonian, the Register Guard, and the Bend Bulletin, We're concerned about the risk that we were putting Medicaid recipients in if the federal government did not approve a 1332 waiver. I know this sounds like very detailed, very difficult stuff to understand, and it is. It is difficult to wade through what a waiver is, 1115, 1332, all sorts of numbers in healthcare.